September is Prostate Cancer Awareness Month. Dr. Stephen Clinton will be joining us to highlight the options for the treatment of newly diagnosed prostate cancer. He'll be joining us momentarily, but first I'd like to take a few minutes just to describe what CancerBridge is and some of the benefits that are available to you as an employee of a company that subscribes to our service. CancerBridge is a cancer-focused navigation service that provides you or your family with immediate one-on-one personalized access to a physician like Dr. Clinton, who is an expert in your specific type of cancer. CancerBridge provides immediate expert guidance at a time of uncertainty. CancerBridge is a simple service with a powerful benefit. You call into CancerBridge and we have a certified oncology nurse that you'll speak with. She'll provide you information, triage the call, and then arrange for you to speak to an expert like Dr. Clinton about your particular diagnosis and situation. After you speak with that cancer expert, our nurse will follow up with you to make sure you received great service and also see if you have any additional questions or see if you'd like to speak to an additional expert about any other issues you may be facing. So when you contact CancerBridge, you'll talk to somebody who's very knowledgeable, who'll listen, and again, you'll get rapid access to an expert like Dr. Clinton, who is an expert in that specific cancer. You'll get a great understanding about the specific cancer that you're facing, and our experts will provide you guidance on next steps in avoiding mistakes through care. This is commonly referred to as navigation. I think most importantly, you'll get immediate answers during this time of crisis. So CancerBridge is not just for you as an employee, it's also for you and your family. So your parents, your in-laws, spouses, partners, children, and siblings are all eligible for the service. They can all call in and talk to our nurses or our experts. All they need to do is provide your name and your employee identification number when they call in. So one of the commonly asked questions we get is, why can't my doctor provide this service? Something important to think about is that there are over 200 types of cancer. That number grows almost every day at this point. Community cancer doctors are generalists with a basic knowledge of common cancers, and they don't have easy access to the expertise that we have, such as Dr. Clinton. All of our cancer experts are each invested in one cancer type. They know all the presentations and latest and best treatments for that cancer. They evaluate and treat only patients with that cancer, and they advise the community oncologists in that cancer. They perform and publish research in that cancer. They lecture around the world. They teach medical students, residents, and fellows about that cancer. And importantly, they know and network with other experts across the world in that cancer, and they can provide access and expertise on which facility you or your family member should be seeking treatment at. To learn more about CancerBridge, you can visit us on the web at www.mycancerbridge.com or speak to your HR team. They'll have a number of resources available to them that describes the services and capabilities that we provide. During the webinar, we ask that if you have any questions, to ask them through the GoToWebinar questions panel. I'll be reading those questions to Dr. Clinton at the conclusion of his presentation, and I'll try to get through all of them. If we run out of time, we may answer some of those via email. But again, any questions that you may have, please ask them through the questions panel in GoToWebinar. Dr. Clinton's presentation will last approximately 30 minutes. It will be followed up by a Q&A session after that. Dr. Clinton, I'm going to go ahead and make you the presenter.
Okay, are we ready to roll?
Yes, we are. I would like to just kind of briefly introduce you while you're setting up your slides. Dr. Clinton is a physician scientist who divides his efforts between clinical care and research. He serves as the director of the Genitourinary Oncology program for the OSU Comprehensive Cancer Center, the James Cancer Hospital and Solove Research Institute, and manages the renowned Prostate Cancer Multidisciplinary Clinic. As I mentioned a couple times, experts like Dr. Clinton are available to speak with you as you call into our service. We're very fortunate to have him. He's a world-renowned expert on prostate cancer. And with that, I'll go ahead and hand it over to you, Dr. Clinton.
Great, thank you, and good morning to all of you who are joining us today. We're going to talk about the new diagnosis of prostate cancer, and we're going to focus on what we call clinically localized disease, which means a patient who we believe has cancer that is limited to the prostate gland and has not spread to other sites. That kind of a discussion about metastatic or prostate cancer that has recurred and spread to other sites can be a wonderful topic for a future discussion. So you heard the word navigation, and indeed, when a gentleman is diagnosed with prostate cancer, this can be a very challenging time to review what are the options and make a decision as to what is the best treatment that each individual may want to pursue. So we're going to give a overview of what are the options and some of the issues that may impact a person as they choose which direction to follow. And
Dr. Clinton,
given that
sorry to interrupt you. We can't not see your slides at this point.
Okay, so what do I do?
Click on Show Screen.
Show Screen. Okay. Done that.
There we go. Perfect.
You got them again?
Yes, sir.
Okay. So you're okay now, ready to move?
Yes, sir.
Okay. All right. So we're going to begin with the very simple question, what is prostate cancer? And as many of you can appreciate, cancer can start anywhere in the body, and it begins from a single cell. Our body, our organs, and tissues are all made up of cells working together to perform very specific functions. And during life, most cells grow and divide in a very orderly way. They also die and are replaced when they are worn or damaged, and new cells take their place. Now, a cell may be damaged through what we call DNA mutations in a way that allows the cell to exhibit uncontrolled growth and travel to other organs. And that's really the fundamental characteristics of cancer. And another point to remember is that prostate cancer, regardless of where it may spread, has its origins in the prostate gland and is still referred to as prostate cancer. So just keep in mind that when it has spread to the bones or lymph nodes, it's not bone cancer or lymph node cancer. It's still prostate cancer. So it begins as a dysfunctional cell that replicates and divides and forms a tumor mass. And eventually, the main problem of cancer is that this tumor mass allows cells to enter blood vessels or lymphatic vessels. They can travel to other places, adhere to the vessel wall, and then extend into other organs. And here's a good example of where prostate cancer likes to go, which is the bones, and particularly those of the pelvic area or spine. So it's the spread to other sites that's important. We're going to talk primarily about cancer that we think is localized to the prostate cancer, to the prostate gland. So what we're trying to do is treat the cancer, thwart the disease at this point so it never can spread to other sites. And that's what we would hope to refer to as a curative intervention. So just like real estate, nothing is more important than appreciating location. The prostate gland is located in the pelvis. It is between the bladder and the urethra, which carries urine to the outside world. Think of the prostate much like a donut around the urethra. Its function is still not extensively well appreciated, but it contributes to seminal fluid that probably is very important in reproduction and successful fertilization. The prostate is intimately adjacent to the bladder on the superior side, and of course on the posterior side, the rectum. So its location means that treatment in this area could easily impact the functions of the bladder, the bowel, and of course the possibility of control of urine as well as sexual function. So the location of the prostate means that certain short and long-term complications of therapy are possible. We've mentioned sexual dysfunction, incontinence or leakage of urine, an irritable bladder with frequency and nocturia, urethral stricture, which means scarring and blockage, sometimes leading to obstruction, blood in the urine. You can have a bowel perforation or injury. You can have irritable bowel problems or proctitis with frequency, loose stools, diarrhea, and in some people, activation of hemorrhoidal problems. And there are other side effects. Not everyone is going to have some of these, but I want you to appreciate as we go through discussion of our options that these are some of the things that can occur during the treatment of prostate cancer. They're not all permanent. There are many things to do for these side effects that can occur. And many people with good care are minimally bothered by some of these complications. But these are the things that you need to be aware of. So how are cancer cells alike? So in one sense of the word, all cancer cells exhibit some similar behaviors. And indeed, it comes through an enormous amount of decades of basic research. And there are these critical hallmarks of cancer. And I'm not going to highlight all of these, but a successful cancer, which is the problem for the host, learns how to avoid immune destruction. It learns how to resist cell death. It has genetic instability, meaning it continues to develop mutations that allows it to circumvent treatments. But the continued basic research allows investigators to generate a body of scientific knowledge that provides new targets for therapy. Many of these therapies are particularly important for advanced disease that spread to other organs, but increasingly you're going to see new and novel approaches that are important for what we call clinically localized disease. Now, how are cancer cells different? Let me just show you this interesting table. The percentage of patients that are deceased or die of a malignancy within 5 years of diagnosis. Pancreatic and liver cancer, the risk of death very high. Lung cancer remains high. Esophageal, stomach. We've made enormous progress in the treatment of leukemia in recent decades. Over my lifetime, this has decreased well over half. And as we march down this list, I want to highlight the one with the arrow. 1% of people will die of prostate cancer within 5 years. And this is because of a number of characteristics. First of all, unlike many of the cancers, prostate cancer is amenable to an early detection strategy. We also have effective treatments. And perhaps more importantly is this unique biology of prostate cancer. It is slower in its progression compared to many other cancers. We do have the early detection tools, as I mentioned. And it's also very heterogeneous. Some prostate cancers are more indolent, slow growing, and really don't warrant treatment, whereas we have others that are very aggressive in their behavior. One of the most important challenges for us is to determine for every gentleman where does his cancer fall in that spectrum from indolent to aggressive. And this will better define who needs treatment, who doesn't, and what type of treatments they should have. And I want to point out that even though only 1% of patients with prostate cancer may have died within 5 years, a bigger proportion of them do have recurrence and spread to other sites. And although the mortality is low and the progression may be fairly slow, having advanced prostate cancer is no fun. And this statement that more people die with prostate cancer than from prostate cancer is true. But on the other hand, having to continually have treatments, whether they be hormone therapy, immune therapy, or chemotherapy, is no fun. And the preference, of course, would be to detect the cancer early, provide treatment that's curative, so that you don't have to deal with it later. So the burden of prostate cancer. This is quite striking. In terms of estimated new cancer each year on an annual basis, prostate cancer is number one other than skin cancer. 19% of all cancer diagnosed is prostate. Estimated deaths, 26,000 per year, ranks number 3. The chance of a man developing this is 1 in 7. The median age is 66. It's the third leading cause of death from cancer. And the risk of death overall for all men would be 1 in 40 and 1 in 6 once you've had a diagnosis. And there are 2.9 million men who are alive in the U.S. having had a diagnosis of cancer, which is truly remarkable. Here is a time frame of cancer changes over time. I'm going to highlight lung increasing from the 1930s, peaking around 1990, and then a steady decline. We're finally seeing the remarkable impact of efforts to reduce smoking. We're going to look at the brown line, which is prostate cancer. A slow rise over the century. PSA screening led to a bump. And what did that mean? That meant that we were picking up more cancers, some of which were more indolent and slowing in their biology. And then we have seen a very progressive and subsequent decrease. I don't think, and I'm giving you my own personal opinion, that there is any explanation for this reduction other than the institution of improved screening. In a subsequent slide, we're going to talk about why that would be controversial when the trend is so positive, but we'll get to that in a minute. It is a disease of aging, and I want to point out for those who remember your math, this is a log scale, and we're going to look at age 40, and what is the risk of cancer? 0.1 per 100,000 men. By the age of 70, it's about 100 per 100,000 men. That represents a 1,000-fold increase in risk as you go from age 40 to 70. Screening. Digital rectal exam, an unpleasant necessity. The finger can feel the posterior part of the prostate, and you can feel for nodules that are suggestive of cancer. A prostate nodule would be like you feeling your knuckle. You're looking for a hard, firm nodule, whereas the normal prostate would feel a lot like your nose. Now, PSA as a screening tool. PSA is a protein produced by the prostate cells. It may be elevated in men with prostate cancer. It may increase due to other conditions like benign prostatic hyperplasia or inflammation called prostatitis. Something called free PSA may help you in your interpretation of the PSA value. A lower percentage of free PSA means a greater risk of cancer. It's a blood test. It's okay to do the blood test after a digital rectal exam, but it is advisable to abstain from sexual activities for about 48 hours prior to the blood test. Improvements for the future in PSA testing most certainly are going to come about. There's something called the 4K score, looking at multiple different types of enzymes like PSA and other molecular tools that are undergoing testing. I think we're looking forward to improvements with time. Now, who should be screened. I'm giving you some of the standard recommendations in black, and then I'm giving you my own personal recommendations in red. And screening should be done based upon a discussion of outcomes with the primary care physician. A baseline screening should be done in men at 45 to 49. I typically recommend 40. And you use age-appropriate values to determine normal. What I mean is, on a blood test result that comes to your clinician, it often will state a PSA less than 4 is normal, above 4 is abnormal. That should be put in context of a person's age. In someone in their 40s, a PSA over 1 should be thought to be abnormal, okay? And I think screening is typically primarily done in men ages 50 to 70. It's recommended by many agencies to do it every 1 to 4 years, depending on what your baseline results may be. I actually feel that it should be done annually. You look for rises of 0.75 over a year to be a red flag that warrants consideration. Current organizations often suggest cutting back on screening after the age of 70, but I see an awful lot of men who are living a lot longer these days than they did in the past, particularly if they take care of themselves and have good medical care. I actually favor screening anyone who looks as though they have a life expectancy of over 5 years or have any new urinary symptoms. This is controversial for a number of reasons. I think the positive aspect is we've seen a progressive decline in prostate cancer deaths. High quality studies of screening to prevent death have never been accomplished in the United States. And the problem with screening is that screening picks up a significant or an important cancer that you need to treat, but also picks up some indolent cancers that may not need treatment. Because of this has led to over-treatment for many men and the complications of therapy that they live with for decades or many years to come. So expert committees have confused the public and primary care practitioners regarding screening. And I think decisions regarding therapy are really what's most important. To prevent overtreatment, it really requires a good discussion about what the treatment options are. Now, how do you find out if you have prostate cancer? Well, it comes through a biopsy procedure. This is done with what's called a TRUS, or transrectal ultrasound. This is a device that's put into the rectum that images the prostate and simultaneously will allow the urologist to biopsy the prostate. This is usually done in a very ordered manner. The prostate generally has a shape like this. This ultrasound and biopsy device will allow the urologist to obtain cores in a very precise grid. Those cores of tissue are about the size of what a line of ink would be from your pen, and they're often just less than a centimeter in length. These then go to the pathologist who looks at them under the microscope, and they assign what's called a Gleason grade to the cancer if they find one. And it just shows you what sometimes is found, what is called a multifocal cancer, here colored on a section of a human prostate. So that's one of the things that you're looking for. So what do you want to know after a biopsy? So a lot of people hear only one thing. Either the urologist calls you or they talk to you directly and they hear one thing: you have cancer. But what you really want to do is collect your thoughts and get all the information. So the first question, as I mentioned, is there cancer? If not, Is there precancer? What's called prostatic intraepithelial neoplasia. What's the volume of cancer? If they did 12 cores, which is standard, how many of those cores had cancer? And for each one that has cancer, what percent of the core is cancer? Is it 1% or is it 50 or 90%? Where is the location? Is it in one area or multiple areas? Next, what is the grade? Gleason score. There's a new scoring system that's being adopted, but most people still focus on the traditional Gleason score. And did your urologist use any new tools, genomics or proteomics or transcriptomics, that help to understand your specific cancer? The Gleason grading is traditionally the most important, and here's a section of tissue on a slide. The pathologist reviews it, and they score it based on the glandular architecture. And I want to just show you this one table as to why this is important. So a Gleason score goes from 2 to 10. We rarely ever see anything rated 5 or below. So a cancer will come back with a 6, a 7, an 8, or a 9, or a 10. And how do we use the Gleason score? The Gleason score tells you about the risk of a relapse of the cancer within 5 years after surgery or other treatments. And you can see if you have a lower Gleason score, the risk of a recurrence is low. If you have a high Gleason score, the risk of a recurrence later is high. So a Gleason score is very helpful in informing a patient as to whether they should pursue treatment or not. Staging is another a point that you want to think about. Staging really is about where is the prostate cancer. So stage 1 and 2 are clinically localized. I'm not going to go through all this data today with all the time. Stage 3 is when the prostate cancer is beginning to invade outside the prostate into local areas, and stage 4 was when it spread to other sites. So we're talking today primarily about options for cancer that is limited to the prostate gland. So what are the treatments for prostate cancer that is detected early and confined to the prostate? So here's a typical sequence of what happens and how you learn about the different treatments. So the primary care does a DRE, PSA. If there's abnormalities, a urologist will then discuss the biopsy procedure and complete that. A pathologist reads and interprets the biopsy. This comes back to the urologist, who reviews the results and treatment options with a patient. Then you'll note the urologist has first dibs here. They're the first one to give a patient the information and convey treatment options. Now, at this time, if there are some concerning features, a radiologist comes into play, because staging study with CT scans, bone scan, MRIs, and sometimes PET scans are brought into play. And they provide this information back to the urologist and indeed any other members of the treatment team. The urologist will then discuss typically the prostatectomy, and in these current years, the robotic prostatectomy is primarily the approach. I've underlined the treatments that are most common and the ones most typically recommended. So the surgical approach is called a prostatectomy, and the vast majority of these done in the U.S. now are robotic, as opposed to the traditional approach of an open procedure. The urologist may also discuss what we call active surveillance or monitoring for indolent disease. If for any reason the urologist feels that the patient warrants a discussion of other options, which we think is an important consideration, they can talk with a radiation oncologist or radiotherapist and discuss external beam radiation, something called brachytherapy, which is seed implants, or a combination of both. And then these other treatments called proton beam radiation, or SBRT, called stereotactic body radiation therapy, and the commercial name or the brand name of that would be CyberKnife. Two other options that are out there called HIFU or high frequency ultrasound, think about it as heat, like microwaving, or cryotherapy, freezing, are available. In my opinion, these do not have the long-term follow-up needed for most men to consider these as reasonable options, and I rarely recommend that except in very unique cases. I think these should be done for patients primarily under clinical trial situations. Now, note, medical oncologists like myself are not typically consulted, and you should participate in clinical trials of treatment if at all possible for the specific situation that you find yourself in. One of the things that we do at the James is a multidisciplinary prostate cancer clinic. This has various advantages. A patient comes, and in one visit, they're seen by urology, radiation therapy, and medical oncology in one afternoon. This also includes pathology review because 10 to 15% of the time, pathologists may not agree on the exact grading and diagnosis. There's also a review of the imaging and laboratory testing. And the goal of this single visit is to reduce the amount of time between your diagnosis and treatment. We can coordinate treatment plans among the different disciplines. There's improved communication among the physicians and nurses. There's decreased variability in what is recommended among physicians. And most importantly, I think this reduces bias in presenting the options. In the old days, when you go to a urologist and then you happen to go to a radiotherapist, each one will tell you theirs is the best treatment for various reasons. And I think they were somewhat incentivized to market their own approach. And I think this improves the application of high quality standards of care, and this increases enrollment or access to clinical trials. So where do we do it? This is in the old James building called the Brain and Spine Hospital, Wednesday afternoons. And again, multidisciplinary surgical team. And this is for men with newly diagnosed prostate cancer or those with complex and multidisciplinary management problems. So options. Active surveillance. The key word here is active. This doesn't mean watch and wait for something bad to happen. You actually have to have a very, very clear and dedicated strategy to monitor this. So ideal candidates for active surveillance are those with PSA that's minimally or very modestly elevated and a slow rate of PSA rise. Gleason 6 and 7 cancers are typically the ones that we would consider. The disease, of course, needs to be clinically localized, a modest volume of cancer, patients who are asymptomatic. This is often the approach for men who have a shorter life expectancy due to age or comorbidities. If people are 85 years old and have other illnesses, active surveillance may work very, very well. The cancer may be slow growing and never really be a problem for the individual and warrants being monitored. The patient has to be comfortable with monitoring, continuing to have imaging, and repeat biopsies at various intervals. Some people who choose active surveillance initially in order to minimize the risk of side effects of therapy actually, in my mind, are stressed by the active surveillance strategy. And indeed, the anxiety of waking up every day and saying, I have a cancer, we're not doing something about it, leads to a psychological and emotional stress that sometimes plays into rethinking what the options are for individuals. So the strategy for active surveillance includes a repeat biopsy, and you want to repeat the biopsy because you want to make sure you didn't miss something. So that's called sampling error. We usually do this by the end of 1 year. PSA is monitored 3 to 4 times per year in my clinic. Others may pick a different number, but we certainly have to have PSA monitoring. And you integrate prostate MRI scanning into the biopsy plan. So the second biopsy is often done with some type of imaging in order to look at the prostate very carefully and make sure that we're biopsying any areas of concern. The risk of active surveillance is that you're concerned that by waiting, the cancer may spread and become incurable. Now, if you focus on the ideal candidates and you're monitored carefully, we think the risk of this would be low. We're constantly readdressing as to whether the cancer is changing and that you warrant moving into a treatment mode. Prostatectomy. These days, the vast majority now in the United States is done robotically. This is what a robot looks like. This is what the console looks like that the urologist is working within in order to manipulate the robot to do the surgery. And I have to tell you, as a medical oncologist who's not a urologist, in playing with these demo versions, it's astounding and just remarkable how well this technology works. It's truly a tremendous innovation forward. And what you're talking about in terms of the surgical incision in the old day, belly button to pubic bone, an incision, and working in what's called an open field with your fingers and tools to remove the prostate. With robotic prostatectomy, you have multiple arms of the robot that are inserted into the abdomen. Air is put into the abdominal cavity, and you're really working in what looks like a cavern. And indeed, what you can see is truly astounding. The advantages of robotic surgery: shorter anesthesia, usually an overnight hospital stay. Blood loss has dramatically been reduced. The need for transfusions has been virtually eliminated. Lower risk of infection, faster recovery, less pain, less scarring, quicker return to normal activities. What's not proven: does it reduce incontinence? Does it reduce sexual dysfunction? Does it cure the cancer better? But there's many advantages as to why, if one can do it, that the robotic approach is superior to the open procedure. There are, of course, risks of having any kind of surgery, and that includes prostate surgery. The acute postoperative mortality is now very low, much different than when I was younger in medical school. You can have anesthesia reactions, and of course blood clots or pulmonary emboli can be a high-risk situation. This is so much lower now that it would be, 1 in many thousand. Infection, perforation of the bowel and bladder. This is rare, but does occur. Problems with urinary function immediately postoperative, bleeding, or a bruise on the inside of the abdomen that can be painful and take some time to resolve, called a hematoma. Longer-term issues for surgery: sexual dysfunction issues, stricture or scarring of the urethra, making it difficult to urinate, incontinence of urine, and lymphedema to the legs. Postoperative visit at 3 to 4 weeks is very critical. This is when the urologist reviews with you the pathology, what's the grade of the cancer from the prostatectomy specimen, how much cancer was there, and how did the cancer invade out of the prostate into adjacent tissues, and what's the status of lymph nodes. Usually a few adjacent lymph nodes are removed at the time of surgery, and you want to know, did the cancer spread to the adjacent lymph nodes, which is a sign that the cancer may know how to move via the blood or lymph. You want to check the PSA. Now, by 3 to 4 weeks, in most men, what is in your blood will have cleared, and the PSA should become undetectable. and certainly it's going to be cleared by 3 months. You want a PSA after surgery that is less than 0.04 at OSU. At other hospitals, what's the lowest number they measure may vary somewhat. Immediately after the acute healing, you focus on the sexual dysfunction issues, the incontinence issues, and work on the rehabilitation. This alone is worthy of an entire talk or presentation. Who may need more therapy is an important question. If there's really high-risk pathology, meaning something called a positive margin, meaning the cancer is right up to where the surgical specimen was resected, or you have a detectable PSA. Then we often consider something called salvage therapy, which is in the past primarily radiation alone. Currently, we often consider radiation and hormone therapy. And a positive margin is when that cancer is right up to the edge of the surgical specimen and perhaps something did not get removed at the time of prostatectomy. The goal of salvage therapy is to use radiation and hormone therapy to cure a local recurrence. What does radiation therapy look like? Well, here's an external beam, conformal intensity modulated radiation therapy, or IMRT kind of imaging. This is the kind of machine that is utilized to provide the radiation. The machine moves in order to provide radiation at multiple different angles. This was a great, great invention because you can see the radiation then crosses right in the middle of the pelvis where the prostate is. So this means that any other area in the abdominal cavity gets much less radiation, so the toxicity has decreased from radiation therapy enormously for men with prostate cancer in recent years. The computers that help design the treatment plan to cover the prostate and minimize the adjacent tissues make the precision of the radiation beam so much better than it ever was in the past, and minimizes the collateral damage to the bladder, rectum, and any other tissues. So remarkable advances there. One of the other things that's frequently done now is that these gold seeds are implanted through a needle in the pelvic area. Here's a pelvic bone with gold seeds implanted to show the exact margin of the prostate, so that every day when you go in for your radiation, the machine lines itself up perfectly with those seeds so that the radiation can be delivered with great precision. So brachytherapy, or the implantation of radioactive seeds. So these are the size of these seeds, and somewhere between 75 to 100 are typically implanted within the prostate. And when they're in there, they are releasing their radioactivity over a period of time. And the radiation to the external tissues then, you see, is much less than from external beam. The key, of course, is getting the seeds in the right place. And so you have to be very, very careful about who you choose to use brachytherapy treatment with to make sure that you have a prostate that is of a size and shape and location that makes it appropriate to insert these seeds, which is done through the perineum or pelvic area between the rectum and the testicles. And of course, it's done under anesthesia. This is a surgical procedure, but fairly safe overall. What are the main complications of radiation therapy? Bowel radiation proctitis, effects on the bladder that cause it to be very sensitive. Long-term effects in the pelvis from radiation could be second malignancies that are either 2 to 3 decades later. This is not very common, would be 1% or so or less, but it definitely is something we have to watch for. I want to point out here, for higher risk cancers that are localized, where PSA is greater than 10, Gleason scores of 8 to 10, high volume, and in men who have many decades to live, we often recommend that the hormone therapy be provided with radiation. Hormone therapy is removing testosterone, usually with drugs, for a period of 6 to 24 months. We know it makes radiation therapy work better for the high-risk diseases. Other forms of radiation that are under study, the SBRT, stereotactic radiation, or CyberKnife. So this is a higher dose of radiation where you only need 5 or so visits to give the radiation. But what we're lacking are the long-term studies. We have reasonably good 5-year studies, but not the 5 to 20-year studies that you really want. The potential for high rates of acute urinary complications is real. This is currently very highly marketed in the communities. They use words like radiosurgery, pain-free, no complications to describe the treatment. It's not quite so simple as that, but it's an area that warrants additional research, and I think it will be an important tool on our shelf for treating men with prostate cancer that are appropriate for this treatment. Proton beam came about 15, 20 years ago. It's a very expensive tool. There's 20 centers in the U.S. with another 20 to be opened over the next couple of years. Very expensive to invest in these centers. And initially it was thought that this would be a more precise type of radiation, give better results. But upon comparing modern external beam radiation to proton beam, there was no proven benefit. And really, as other forms of radiation improve, we're not seeing the big push for proton beam that we did 10 or 15 years ago. So clinically localized disease, how do you choose? Well, a lot of it ultimately is personal preference. We have men that come in and say, you know, my mother had this kind of cancer, or my father that kind, or my brother or sister, and they did surgery or radiation and we didn't like their outcome. So many men coming into this have personal experiences that unfortunately bias their ability to objectively assess what their options are. But with time and good education, I think we can get around many of those issues. Convenience is a factor. Many men are working or have travel plans or children getting married in X time coming up. And so there are these convenience issues that play into making an appropriate decision for that person. Some folks don't live close enough to radiation therapy centers where travel and the inconvenience of getting external beam for 7 weeks every day becomes an issue. Each person has a comorbidity status. So men who are relatively healthy have more options. Many men who maybe have had cardiac or cerebral vascular, meaning stroke, blood clot issues, on anticoagulation or other diseases, this will impact what kind of treatments would be more appropriate to choose. And many men consider what the portfolio complications may be. And some men are more concerned with the sexual dysfunction that is very prominent with the surgery and perhaps less so with the radiation. And certainly active surveillance for indolent cancers mean that you're going to avoid many of these treatment-related complications. One thing you can't do is make a choice between radiation and surgery based on cure rates. Indeed, both radiation and surgery can have very excellent cure rates for the selected individuals with similar long-term survival. So I view much of what we're doing in advising men with clinically localized disease as much like going to the tailor and getting a suit that fits you. You're looking for what is the best treatment for that individual, and taking into account all of these considerations and helping an individual facilitate a decision. Now, I just want to make a final statement about clinical trials. Let me give you an example of a clinical trial for men who presented with a, say, high risk, high Gleason score, or PSA that was between 20 and 100, but yet no evidence of disease that had spread. So here is a wonderful trial that is now completed but being monitored. We do not know the results. So many of these men might have come in and chosen the standard of care of prostatectomy. Well, this trial randomized everyone to the standard of care prostatectomy versus having 6 cycles of chemotherapy and 24 weeks of hormone therapy, then going to prostatectomy. This is a very large study of 750 men. This was done throughout the nation, and it's being monitored now. Should this arm prove to be better, this will now become the new standard of care. And we're eagerly anticipating this. I mean, this is very, very similar to studies that were done in breast cancer 30 and 40 years ago. Now, prostate cancer is decades behind because the research has been slower to develop and not as well invested in. But we now, in breast cancer, integrate chemotherapy and hormone therapy and surgery into the care of many women with high-risk localized disease. And we truly don't know if this chemo or this modest duration of hormone therapy will make an effect. So it's an extremely important study. And in the Columbus and Central Ohio area, we had 75 men on this trial. And that was literally 10% of all the men in the nation that enrolled in this trial. So hats off to the Buckeyes for participating in this really important clinical trial. I'm going to say a couple words about these 2 important questions that often come up. Why did this happen to me? And what about my family, brothers and sons? So it's very hard in any individual to really state why exactly did this cancer develop in you at this age. Many, many people are very interested in the role of food, nutrition, lifestyle, exercise. I'm going to refer you to this website, the American Institute for Cancer Research, for the diet and nutritional guidelines that would be appropriate for cancer prevention, not just prostate, but all types of cancer. And they're a very, very informed and excellent organization defining these guidelines. And with regards to genetics and concern for family members, more and more hospitals around the nation are opening cancer genetics clinics. Here at OSU and the James, Heather Hampel directs this program for us. It's an outstanding program where we have specialists in cancer genetics, where we can define and review the family medical history, determine if there are genetic tests that are needed, what is the cancer risk for you and family members, and you can participate in research studies. Now, with prostate cancer, I'm just going to say a couple things. If you have a first-degree relative, a father or brother with prostate cancer, particularly at a young age, this may suggest some component of an inherited predisposition. Now, understanding prostate cancer genetics is just in its infancy. We're just beginning to understand it. But there's no question that if a young man in their 40s, 50s, early 60s has prostate cancer and they have siblings, it's a good moment in time to advise your family members and suggest that they talk with their primary care physicians about screening. If a gentleman has prostate cancer, again, at a particularly young age, and they have male children, I definitely would emphasize having screening start at least by age 40. Now, I'll stop at that point, and we're happy to take any questions that we may have time for.
Well, thank you so much, Dr. Clinton. We're all very fortunate to have you available to us as a resource. I will go ahead and start thinking through questions. We've had a number come in. So This first one here is an annual digital rectum exam recommended years after a brachytherapy treatment?
So if your prostate remains after brachytherapy or any kind of radiation, I do recommend that one continues to have a DRE, which is other than just the embarrassment of it, it's not really a risky procedure. And I think often people will monitor the prostate and the PSA because you can have a recurrence within the prostate. And I think that's the reason you should continue to have the PSA and the annual exam following radiation therapy.
Okay, great, thank you. Can you address the thought that a biopsy may help spread the cancer?
Yes. So there have been a number of studies of this at big institutions where they do a lot of biopsies. The most well-known one is out of Johns Hopkins University. And the chance of a biopsy spreading the cancer is almost infinitesimally small. It's exceptionally rare. I may have seen one maybe over 30 some years. So it is not a good reason to avoid having a biopsy if it's recommended.
Okay. Understood. A long question coming through here. If a PSA stays under the 0.7 rise over a year, but in time you increase your overall PSA level, at what level should something be done?
Well, PSA screening will improve in the future when we have a different set of standards of what should be the red flag or the indicator of concern. And I look at two things: the absolute amount of PSA, and that should be based on age. So if you're under 50, a PSA should be below 1 for sure. And if you're in your 50s, it really should be below 3. When you're in your 60s, that standard of 4 and above is okay. And so I think it's age dependent. Now, so you watch the absolute value, but then you're looking for in any 1 year, did it go from 0.5 to 1.5 in a year? That rise of 1 would be a red flag for me. Now, would I go right to a biopsy? Perhaps not if the DRE is normal, but I would certainly repeat that PSA within a couple months. And if it's still elevated, that would be a reason to discuss a biopsy with a younger man.
Okay, understood. Again, just a lot of questions coming through here. I'm trying to make sure we haven't addressed some of these. One came in here on the side effects of proton therapy. How do the outcomes and side effects of proton therapy compare to the other treatment options?
Sure. So when proton beam therapy came out 15, 20 years, the thought was it was going to provide much more precise radiation than the traditional external beam. And perhaps 15 and 20 years ago, that would be true. I think now, because of the higher quality imaging and the computer technology to provide conformal radiation, that they're having very similar portfolios of side effects and similar outcomes in terms of what appear to be cure rates. And so the logic of using proton beam may have been there 20 years ago, but it has progressively declined in the years since as the other forms of radiation have improved. So I think the kinds of side effects from proton beam and external beam are the same concerns. If you don't get the beams aimed at the right place, you can irritate the bladder, you can irritate the bowel, and overall the portfolio of side effects are similar.
Okay, understood. I'm going to kind of combine a couple questions here.
Sure.
So a couple things have come in around herbal supplements, CBD oil treatments.
Sure.
Looks like a large dosing of vitamin D3. Do you
Yep.
have any thoughts on those, or can you point people on?
Lots of thoughts, yes.
Yeah.
So listen, all of these things that we're offering to treat people were tested through decades of what are called clinical trials. And you want to provide what's called evidence-based recommendations for those at risk to prevent cancer, and also evidence-based recommendations for what kind of food you should eat or supplements during treatment. And thirdly, what should you eat and consume after treatment to reduce the risk of recurrence. All those issues are very, very important. What's unfortunate at this point in time is that real randomized controlled clinical trials are very few. The one study that looked at prostate cancer prevention with a nutritional intervention compared vitamin E and selenium, and quite stunningly, actually some of the risks were increased by the supplementation. And so were some other disease processes like the risk of glucose intolerance, et cetera. So sometimes we've got some wonderful animal studies or studies in cell culture suggesting that certain nutrients may be important, but we don't have the clinical trials to make definitive recommendations. And the vitamin D one is very interesting to me. We're doing research on it now. But do we have a study that proves that it will benefit a man with prostate cancer or prevent the disease? We do not. And some of the other studies that were done, I'll give you a great example of something that was called PC-SPES 20 years ago, which was a combination of herbal supplements from China marketed in the U.S., was tested in a clinical trial for advanced disease and showed a benefit. So what happened, unfortunately, is there were a stunning increase in a number of certain complications. And when someone analyzed this herbal product, they found that it was spiked with drugs. So non-steroidal anti-inflammatory agents that reduced pain, estrogens that in a man is a form of hormone therapy, but that causes heart attacks and blood clots. And then this medicine was also spiked with a blood thinner to thwart the blood clots. So here we had an herbal product that was tested, but ultimately proven to be fraudulent. So there's this word caveat emptor, or buyer beware, at the moment. And I think what we really need is more investment in clinical trials.
Yeah, thanks for addressing that. That was the topic of a number of questions, and I would just add to that too. If you have specific questions about that, or just other treatment options in general, you're always available to contact the CancerBridge navigation line, and our experts can help guide some decision making there. And we are getting a number of questions about specific family history, specific genetic testing based off of family conditions. Again, I really encourage you to contact our service at 855-366-7700, and our nurses can guide you through these genetic testing questions and get you in touch with some of our experts. I think with that, Dr. Clinton, I think we're going to wrap up. Again, I really appreciate your time today. I know all of our audience does. We're really lucky to have you as a resource, and I'm so thankful you were able to join us today.
Great. Thank you, and good day.
All right. Thank you. Bye, everyone.
Okay. Anything else I need to do?